see. I will check from that
Yes, ma'am.
allergy.
I think it
And
is done
The
now. It is on
yeah, it
YouTube.
is done. It is being live streamed.
okay. Okay, great.
Can we start?
Yes, we can.
Check
So
from
many,
that
I did with the
I think
password
the-
and everything.
It is.
It
Yes,
is
it is
live.
done. It is
live.
being
Yeah.
live streamed.
It is live. It is live.
Okay. Okay,
Done.
great.
Can we start?
Yes, yes.
Narayan Reddy, sir, can we
Check
So
start?
from
many,
that
I did with the password and everything.
It is.
It is
It is done. It is being live streamed.
It is live. It is
Okay. Okay, great.
Can we start?
Yes,
Yeah,
yes.
we start in time.
Good evening, all. I think I'm Dr. Soumya Nagarajan, and I welcome you to the first edition of the Allergy India Dialogues. I would request Dr. Upin Narayan Reddy, sir, the chairperson of IAP Allergy and Applied Immunology 2026, to say a few words about the Allergy India Dialogues and to address the gathering.
Good evening, everyone. I welcome on behalf of Allergy Applied Immunology chapter. So this is the first session, Allergy India Dialogue. So this is started because to involve all state chapters, local faculty. So this is very important, I think, initiative started with what's about the today's speaker is Bholanath, is secretary of the Calcutta branch, West Bengal branch of Allergy chapter, under the Dr. Sanjukta Madam President, about myths versus facts about allergy. I think it is we are going to involve all state chapters this every month. This is going to be very useful to the local talent should be utilized. This is very, I think, all the best for you. So over to Soumya.
Ma'am, you are mute.
Joseph.
Before you start, yes, sir. Before you start, it is my pleasure to introduce you, sir, as he's a consultant pediatrician and pediatric allergologist. He's an assistant professor in the Department of Pediatrics in Murshidabad Medical College and Hospitals. After his MD in pediatrics, he's a fellow from in Neopocus from Pune. Done his diploma in allergy and asthma and immunology, and the IAP certificate course in advanced asthma courses. He has been part of the EB for multiple years. He has been the part of the president secretary of the allergy chapter, president of his own district, and he has more than 9 publications with 7 international papers. He is a well-known speaker in both the national and international conferences. We are very happy to have you as our first speaker for what promises to be a year ahead of learning in academies. Over to you, sir.
Before that, I'll request past chairperson Neeraj Gupta sir a few words, remarks.
Thank you, Reddy sir. I think this is a very noble initiative which has been started by team led by Dr. Reddy sir, Dr. Soumya, and Dr. Mitesh. And this is something, as we understand, that in past few years, allergy itself has evolved so much in our country. And academic front point of view, we all have grown together up till such a level that I think to each part of the country, each nook of the corner, we are getting, you can say, like the noise about allergy from the patients, from the physicians, from the pediatricians. So now it is the time that we need to now nurture the next generation of allergists, and we need to now prepare the next layer of defense. And I think this is a very right move at a appropriate time to involve now all the people who are doing good work but probably not getting recognized adequately, amply. Now, by this initiative, which is Allergy India uh, Leadership or Thought Initiative, which is a very good initiative. And I must say that through this dialogue sessions, everyone across the country from different states will get the opportunity to come forward and become one of the national leader. And simultaneously, other states also who are yet to be, you can say, like a official part of allergy chapter, they will also be getting an inspiration to join us, and all other people will be able to join us to make it a good momentum. So very nice initiative, sir. I would like to congratulate everyone and my best wishes. Thank you.
Okay, Joseph,
Over to you, Bholanath, sir. I think you can.
we'll start.
Thank you, sir.
Yes, sir. Yes, sir.
Thank you. First of all, it's a thank you for giving us the honor to present in this auspicious platform, sir. We are deeply honored for this, sir. So, is my screen visible, sir?
Yeah.
Yes, sir.
Kindly go to the slideshow, sir.
Yes, sir. So, should I start, ma'am? Yes.
Yeah, start.
Yes. So a very good evening to all the respected members of the Indian Allergy Academy of Pediatrics Allergy chapter. I must be very grateful to all of you, especially to Neeraj sir, to Dr. Upinaran Reddy, to Soumya madam, and to my own Didi Sanjukta Di, who has guided me very well in my journey to this platform. So today this topic has been selected as because when I started my journey in the field of allergy, I have been hit with many myths. And many of these myths were so vicious and so discouraging that I sometimes thought that I should not be in the allergy practice anymore. So then, as I go through this allergy subject, I just came out with that there are many of them, they are myths and they are far away from the facts. So when I start my journey, that was the most common word that I have been told to. Please stop. This is not safe. You cannot do it in your chamber. This is very dangerous. You can be sued. You can be face many legal problems. So please don't go into that. The second is being a pediatrician practicing allergy. It's not possible because the children will not cooperate you. There are many other problems. You cannot go through it. And then third was the most discouraging. It's not very effective. You will have to go back. So I was very much confused on that. And thank you, Joseph, sir, for introducing me so well. Thank you, sir. So this is the first myth that we face in our day-to-day practice, ma'am. That is that allergy, hypersensitivity, atopy, they are all same. I just can remember my MBBS and my MB pediatric sessions, my postgraduate sessions, where it was these three terms were very frequently interchanged among each others, as if they are all same. Now, what is an allergy? Allergy is a clinical manifestation of an abnormal or an excessive clinical response to a substance or an allergen in a susceptible individual in a dose that is usually harmless to normal people. So it should be a clinical response in a way which is not producing in a normal individual. Now, hypersensitivity is a broader term. Now, whenever we just been exposed to some subject, some product, and we get some kind of adverse reaction, this is hypersensitivity. This hypersensitivity may be immunologically mediated, may not be immunologically mediated, but this is reproducible. As long as I'm getting exposed to that particular substance, I'm getting a symptom. If that particular symptom is not immunologically mediated, this is not allergy, but this may be hypersensitivity. The third one is an atopy. Where there is a family history. My father is allergic to something, my mother is allergic to something, my father has asthma, my mother is asthma. So I'm an atopic person and it's likely that I can get those allergy in future. So this is a myth only and not a fact. I'm just going to that one. So this is false. So the next myth that comes to me is that all allergies are Ig mediated. If there is no Ig, there is no allergy. So what is the fact? The fact is that an immune reaction, they may be divided into an Ig mediated reaction, which may be a type 1, or they may be non-Ig mediated, which are ranging from type 2 to type 4 kind of reaction, or eosinophilic diseases. And immune reactions are mostly mediated by mast cells, so they are Ig mediated. We usually, they are allergic rhinitis, asthma, urticaria, and we had some set of tests like skin prick test, like specific Ig tests, they can be done to it, and they are used to diagnose this disorder. We can also go in this particular kind of patients, immunotherapy, and also use biologics. And in case of non-Ig mediated reactions and mixed Ig mediated reactions, they are typically T cell mediated. So they usually tend to occur a bit later, 4 to 48 hours after exposure to the offending allergen. And there are many examples like FPIs or FIPAP, and also mixed eosinophilic esophagitis. So this is partially true. Yes, Ig is responsible for many cases of allergy, but it is not always that only Ig do all the problems. Now, this is a scenario that I think we all, the practicing pediatricians that face in our day-to-day practice. A raised total IG does not diagnose. So an elevated total serum IG is a must for diagnosing allergy. If you do not have an elevated serum IG, then this is not an allergy. So the fact is that a raised total IG does not diagnose an allergic disorder and is never in isolation is an indication for a specialist referral. Now, elevated total serum IG, they are commonly seen in case of allergic disorders, but this is not diagnostic. Asthma, eczema, allergic rhinitis, and food allergy, in many of the cases, they can be present with a normal serum IG level. So the most important part in diagnosing allergy is always history, without recourse to laboratory testings. And very high levels are very common. Eczema with staphylococcal infections. India has a very high parasitic load, so used to have a very high IG levels. So these things can happen. And there are some disorders like hyper IgA syndromes, where we also get a high IG levels. But in none of the cases, this is a high level of IG is diagnostic of that. The measuring total serum IG therefore adds very little to clinical history in most of the clinical settings. So this is a false myth. So the question comes, where is this total serum IG is important? Where should I go for that? So we had a set criteria for diagnosing of allergic bronchopulmonary aspergillosis. So these are very important, one of the important criteria for diagnosis and follow-up of allergic bronchopulmonary aspergillosis. For allergic fungal sinusitis, in hyper IgA syndrome, we used to get this value very high. There are some clonal muscle IG disorders where we usually get a high IG levels. And it's also elevated in HIV infections, in lymphoma, systemic parasitosis, even in some cases of tuberculosis. So these are the areas that are total this is I faced in my from my MBBS days, that absolute eosinophil count are a must in all allergy diagnosis. So if there is not elevated eosinophil count, this is not allergy. So what is the fact on that? A peripheral blood eosinophilia, which is around more than 500 eosinophils per microliter, they can be caused by not only allergic, by infectious, inflammatory, and neoplastic disorders. So that could be primary eosinophilia where there is hematological malignancies. They can be secondary eosinophilia, which are reactive, or they may be idiopathic eosinophilia, but no identifiable causes are can be identified. But combined elevation of both the serum IG and absolute eosinophil count, they can be taken as a dependable marker for allergy, although history never overtakes, history always overtakes this. History should not be take aside only these biomarkers. Now, the raised absolute eosinophil count, they can be used as a prognostic marker for determining the duration of therapy in allergic rhinitis. Also, in case of allergic bronchial asthma, raised eosinophil count does mean that this kind of disorders may be very, very severe. And in that cases, while managing these cases, we used to go far beyond from our usual managements to biologics and to some other drugs. So this is also partially true and not 100% true. This child comes to my chamber. Is a 4-year-old beautiful girl, has a fever for 3 days, moderate grade intermittent fever. The child was normal, playful, while afebrile in between. Now, day 3, the child has developed an itchy rash. It was a papular rash distributed all over body parts. And mother just came to my chamber, was very anxious. Just tell me very simply, what medicine you have given to my child? The child has developed allergy. I was very shocked. This is a very beautiful child, and I used to see this child quite often in my chamber. And so I just have to answer something to the mother. So my answer was, infections are most common cause of urticaria in children. So there are rotavirus, there are rhinovirus, there are Epstein-Barr virus, there are herpes simplex, HIV, hepatitis A, B, C viruses. So the many cases of, I just see cases of this kind of rashes. In a few days ago, the child was suffering from mycoplasma, which is diagnosed by biofire. So the child develops urticaria. H. pylori infection, some cause of streptococcus. Now, there are some medications also, definitely, they can cause this kind of drug allergies. So this kind of arterial rash, these are beta-lactam antibiotics, aspirin and vancomycin. And if the child is exposed to food, then the food can be a cause of that. The food additives that are present with that, or there are also some cases of pseudo-allergy where there is direct muscle stimulation that can go to that. And we also take the history of the insect bite. So these are the causes, of which infection is the most common. So it's probably the infection that has led to this urticaria and not the drug. So how to approach when the parent comes to you with a new onset urticaria? So this is a guideline that I have taken from the UpToDate. So when the patient is coming with symptoms of urticaria, the first thing that we have to know, we have to understand is that whether the child is having any anaphylactic attack or not. If the child is having an anaphylaxis, the first job is to stabilize the child. And then if it is not anaphylaxis and the child is stable with only arterial rashes, then we just have to look whether the lesions are painful, lasting for more than 24 hours, and having residual purpura or ecchymosis. Now, if these things are positive, we may are looking into a case of vasculitis. Now, if no, then we just have to see whether this urticaria is a simple urticaria, acute urticaria, or there are some bigger pictures lying behind that. So you just have to look for if there is an unintentional weight loss, if there is unexplained fever or not, and arthralgia or arthritis, and the presence of lymphadenopathy or not. So if these things are being negative, then you just have to see the disease behind that. We have to look for whether is infections present or not, viral infections, bacterial infections, parasitic infections, including common respiratory viruses at the time of presentation or even a previous few weeks. We have to check the medications, we have to check for certain insect bites, we have to check for the foods, we have to check for certain allergens, and we have to check for the cold, exercise, or other physical triggers. And then we just have to manage the child. Now, then mother tell me, we should go for an allergy profile immediately, doctor. So I was very stunned. The mother is so much Google friendly. And so I just have to answer, mom, what is the role of an allergy profile in allergy cases? So allergy profile is a specific IG assay where sensitization is detected against a set of allergens. This can be a skin prick test. This can be a blood test. In my area, most of the tests which are available are ELISA based, as this is very cheap. But we all know that this test is now obsolete. There are some extract-based or component-based immunocap tests which are available right now. But in most of the cases, they comes with a set of antigens, 100 tests, 150 tests, 200 tests, 240 tests. So this is a set of tests. In most of the cases, they do not correlate with the history. So my answer to the mother is, it is history which is most important to suspect allergen. So select your antigen after taking a good history. That should match, that should be reproducible, and they correlate clinically. History needs to be rechecked after test report available, because this is only a sensitization, and whether it is the actual cause of allergy need to be confirmed by taking the history once more. So no, absolutely not. We should not go for an allergy profile immediately with the new onset of urticaria patient comes to us. We need to stop all foods that can cause allergy after urticaria. Now, that was the advice given to the mother by her in-laws, that as your child has developed an allergy, so what you should do, you should stop all the allergic foods. You should stop now cow's milk, you should stop wheat, you should stop egg, you should stop all the fishes, stop everything. Now, this is a scenario that we used to face in our day-to-day practice. The child has become nutritionally poor because he has to stop all of these. The child's mental status has to go down because in a family program and the family functioning, everyone is enjoying their food except that poor child. So the answer from my side is that there was no food is universally allergic. Urticaria, which is mediated by immediate type of hypersensitivity reaction, they usually come within 30 minutes to 4 hours of ingestion of food. And as it is a very short time, so keeping a diary of the event or a food diary is very helpful. Recheck it. Food doesn't contain the food only, as I have seen in many of the cases. Today's the fast food which are available, and also the many foods, packaged foods which are coming to us, they had many kind of food color, the taste enhancer, the food preservatives, and many other things which are added with them. That can be the cause of the problem as well. Now, if the history is suggestive, you stop taking those foods only for 2 to 4 weeks. Then you go for a skin prick test or a specific IG assay, or you can be very sure that the SPT is negative and the skin prick assay is not showing that positive result. Then you can go to a oral food challenge test, which is the gold standard, but you have to do it in an allergist chamber, not in your home and not anywhere else. Lastly, if the standardized antigen is not available, then we can take the fresh food and we can straightforward go to a prick-to-prick test. This is only applicable in case of food allergy. So by this way, we can find out what are the antigens which are causing allergy and then go to avoid them. Not stop all the foods, because no food is universally allergic. So this is false. Now, this is another problem that common pediatricians face in day-to-day practice, that any bad reaction to a drug is allergy. Any kind of reaction. I take the drug, I develop vomiting. I take the drug, I develop abdominal pain. So this is allergy. Now, the fact is that the most are non-immunological adverse drug reactions. actual incidence of drug allergy is actually very low. It's only 5 to 10%. Now, the true allergy should always involve the immune system, and they usually comes with some kind of skin manifestations like hives, itchy rashes, anaphylaxis, but not always. Yes, anaphylaxis sometimes comes without any skin manifestation. There is cardiovascular symptoms, there are respiratory symptoms. We have to look in that. Most allergic drug reactions occurs within hours to 2 weeks after taking the medication to which they are exposed in the past. So there should be a stage of sensitization followed by the re-exposure, and after re-exposure, there is manifestation of this allergy. So history will be very important here as well. And there are many other agents which are present in the drug, like coloring agents, like preservatives, like impurities in suspension or syrup. They also can cause the adverse drug reaction, and not always. So an adverse drug reaction is a big umbrella, and drug allergy is only 5 to 10% of it. Rest of them are non-immunologically mediated drug reactions. So it's not also true. This is a scenario. The parent comes to us and tell me, don't give paracetamol. His father is allergic to paracetamol, so don't give paracetamol to my baby. A very common scenario, and we also get confused with the when the question comes to this way from the parents, because they have gone through the Google, and Google has told them that allergy is familial. So the answer was, if the father is allergic, then the child may later develop some kind of allergic problems. The chances of developing allergic, like allergic rhinitis or allergic asthma, yes, this is more. But allergy to a particular drug is never inherited. So if the father is allergic to paracetamol, the baby can take it. We just have to see whether the baby has developed a reaction or not. Now, in some cases, there are some specific gene types such as HLA-DR3. These drugs are mostly used in case of rheumatoid arthritis. They can some sort of reaction, but these are very few in number. So I'm not going in details of that. So this is also false. Now, this is a scenario that we face in one of the sub-region hospitals in our seaboard or coastal areas of West Bengal, where a child who has taken a shrimp and has developed an anaphylaxis. When he was taken to that particular hospital, and epinephrine was available at that time. It's around 5 to 6 years ago. This incident has happened, and the doctor over there has given him Sirafenargan, because that contains anti-allergic, and this is an allergic reaction to him. And he never gave epinephrine in spite of having that. It's because he fear if that he give epinephrine, it's a very dangerous drug. The child can develop severe tachycardia and many other side effects, and the child ultimately dies. So the notion is that epinephrine is a dangerous drug. Give it only in a severe life-threatening reaction. Better give antihistamine. And the answer is an intramuscular injection epinephrine, which is available in 1:1,000 ampules in our country, is the first choice drug in anaphylaxis. There is also EpiPen available, but this is very, very costly, not affordable to many of us. This is safe, life-saving, and very, very effective. It is often underused due to fear or failure to recognize a severe symptom. We wait unless the child collapses. So if it is given very early, the result is very, very beautiful. It comes very early, and antihistamines, they only help to reduce the skin itch, the skin hives, and they should never delay the use of epinephrine. So this is a message straightforward goes that this is a very dangerous myth. This needs to be broken. You should keep intramuscular injection epinephrine in your hand and give it whenever required. Now, many parents are now very pet friendly, and that is also very good because pets are very lovely. If you are allergic to cat, you can keep a dog because dog is hypoallergic and it can reduce the allergy of the cat. I, in my own ear, has heard this from one of my patients. So, and the answer to the myth is that no dog is 100% hypoallergic. Yes, they have different antigens. The cat allergen is FeLD1, which is present in the saliva, skin glands, and urine, and dogs has CANF1. You may be allergic to the cat-specific protein, but not to the dog-specific one. You can be allergic to cat and dog both. Now, the cat allergen has some sort of antigens such as RFLD2, RFLD4, RFLD7. Now, this can be cross-reactive with the cat antigen at the same time. So, if you like to take a dog in your house, what are the steps that you should take before getting a dog? First, if you are allergic, you get tested. You test yourself for cat dander and dog dander, and then if you are negative to that, you can take this dog inside your house. And then test exposure. You get exposed to that particular person, come play with that dog, and if you develop some kind of symptoms, then you must understand that you may be allergic to that particular dog. There are some hypoallergic dog breeds which has short hairs. They usually shed lace. So these are the dogs that can be chosen. if you really consider a drug, even if you know that you are allergic to dogs. So these are the scenarios that you can go into that. So this is partially true and not actually totally true. Coming to food allergy, this is the shock that I always get. There is a notion that it sticks in the minds of parents and also doctors like us and the common pediatricians that once you are allergic to a food, you are always allergic. You can never take that food as you are allergic to that particular food. And the answer is that the child mostly outgrows allergy to milk, wheat, soy, and egg, with 80 to 90% of this resolving by age 5 to 6 years and up to 90 to 95% by the age 16. So in most of the cases, 90 to 95%, they get out of this very common food allergens by age 16. But allergies to peanuts, tree nuts, fish, and shellfish, they are less likely to be outgrown, with only 20 to 25% of the peanut allergies disappearing by age 8. If it is not disappearing by age 10, it is likely to be lifelong. Now, if the child who is allergic to milk or allergic to egg can tolerate baked milk and baked egg, they are likely to outgrow these allergies faster. So we have to just give them, and then we can understand whether they can get out of this or not. So this is basically false. So how do you know that I'm getting out of food allergies? The sign of progress is there is a decrease in the level of specific IgG antibodies in the blood. If we go for a skin prick test and we see the dimension of the wheal and it gets down after 1 year, after 2 years, I can safely say that yes, my allergy is going down. It should be monitored by an allergist, suggested a child will be outgrowing the allergy. Now, how to confirm? In case of food allergy, we should go to an allergist. This is a must. We should go to the office of an allergist. This should not never be done at home. We used to go for an oral food challenge to safely determine if the allergy is gone or not. Now, never try this at home because this can cause a severe allergic reaction, even anaphylaxis. So this has to be done in an allergist chamber with every items available in hand if there an emergency lands. So this is the way we confirm. This is another myth. Stop giving allergic food to mother during pregnancy. It will stop allergy in baby. So mother has allergy. It can go to the baby. Stop giving those foods to the mother. Baby will not develop allergy to that particular food. Now, is that myth is true? So there is no evidence that the maternal dietary restrictions during pregnancy or lactation prevents food allergies. A diverse and balanced maternal diet, which is aligned with the cultural norms, they may promote immune tolerance in fetus and in infants to exposure to a variety of food allergens. And there is significant evidence, there are more slides on that later, that restrictions of the specific allergenic foods in pregnancy and lactation that does not confer any protection against food allergy development in infants. So stopping the food in mother does not stop the development of the allergies in the infant in the early part of life. In fact, maternal peanut consumption that has shown a potential protective effect on the peanut allergy development. So this is also a myth which is going on for a long time, for which the mothers are deprived of good nutritious diet, and ultimately the baby suffers and the baby doesn't gain anything from that. So this is also a false myth, not a fact. So another myth, eating a little bit of a food that you are allergic won't hurt you. Now I just go back to that same incident that I was just telling a few minutes ago regarding that poor boy. He was allergic to shrimp and he went to Digha. It's a very good coastal area in coastal tourist spot in West Bengal. And as everyone was enjoying the prawn, the child take a few bits of prawn and doesn't develop something very immediately. So the rest of the people who was with you, they tell the child that thoda sa kha liya, no problem, you can go on. And the child then developed the allergy. So the problem is even a trace amount of food allergen can cause a severe reaction called anaphylaxis in some people. The food a person is allergic to must be completely removed from their diet to stay safe and live well. And also there should be avoidance of the cross contact, because if that particular food allergen to whom I'm allergic to comes in contact with those food which I am supposed to be safe to, can land me in trouble if there is any sort of contamination with the allergic food with the safe food. So this is also a myth because sometimes allergic reactions take time to develop. So this is false. then this comes with now the many patients are coming with us with report of allergy test available. They are very proud. They tell me, Doctor Sahab, हमने एक allergy panel कर लिया. We just do an allergy panel. So just see, I'm allergic to all this. So this is a myth that if a food allergy test is positive, you must have a food allergy. And the fact is that this is only a sensitization. A positive skin prick test or a blood test results for a food allergy are not always accurate. Even ELISA method gives plenty of false positive cases, and other methods also a bit lesser, but ELISA gives plenty of false positive cases. So this result is positive even though you are not allergic to that food being tested. So we just have to go back to the history and check whether after exposing to that particular food, the child develops symptoms or not. If the child does not develop any reproducible symptom to a particular food to which the allergic test comes positive, the child can take it. If there is very strong suspicion, no, I'm allergic to that particular food and the test has also come positive, then we have to go for an oral food challenge test, which is the gold standard. Now, as per the book guideline, we have to go for a double-blind placebo-controlled food challenge test, now, which is basically used in many research areas, but not in general practice. We mostly go for an oral food challenge test. And this oral food challenge test, where the patient and the doctor both knows that what product is given to the child and the child is allergic to that particular food, we used to gradually increase the dose of the food, and then we see whether the reactions are coming or not. And that has to be done in the room of a allergist. And this will confirm whether this allergy is still present or not. So it's not a blood test. Clinics is very important. And if still that doubt persists, then we can go for an OFC. So this is a false myth. Now, this is if you don't have an allergic reaction within 30 minutes of being exposed to your allergen, you don't have one. So this is some myths that going on because everyone loves the kids and the kids are missing food is very bad to the grandpa, the grandmas. So थोड़ा सा खा लो, कुछ नहीं होता. तुमने खा लिया, आधा घंटा हो गया, कुछ नहीं हुआ, तो तुमको कुछ नहीं होगा. So these are the things that coming on. And in many of the cases, as in the rooms or in many of the homes, the mother are not the decision-making authority. So grandmas and grandpas pressure, most of the cases come into play, and childs are being exposed to this kind of incidences, and they ultimately develop some kind of symptoms. So the symptom can develop not immediately, but it can take up to 2 hours for the symptoms to appear. But the more dangerous is that even after the first symptoms go away, a second round of symptoms can occur without any re-exposure to that allergen. So the first reaction goes, we give some medicine, then I'm not being exposed to that particular food, but I get some symptom within 48 hours. That can happen. Now that is a biphasic reaction which can happen. And many a time this second reaction is much more dangerous than the primary reaction. So you have to keep it in mind that we should avoid it. If this is a very serious kind of allergic reaction, we should avoid it. This is also false. This is a case which has caused a very bad trouble in one of my friend's chamber. The parents who has come with this report belongs to Jain family. He's very stick to their vegetarian diet and has come to be allergic to shrimp. Now we allergists know what is the cause of that, but in that period, it causes a very bad upload in the chamber. So the primary sensitizer here is not the shrimp. It is the inhaled tropical house dust mite. And these allergen act as a primary sensitizer regarding an immune response that may later cause an allergic reaction when eating the shrimp. It may cause, may not cause, but when we go for the test, especially test with the skin prick test, it will show me a positive reaction. Only when we are just looking for the extract-based tests, or we can looking for the crude level test like the skin prick test. So the shared antigen here is a tropomyosin, which is present in both the house dust mite and also in the Clostridium species. And the Ig antibodies produced against the tropomyosin can cross-react with the shrimp tropomyosin. So it's not actually allergic to shrimp, it's allergic to house dust mite, and this come positive. The clinical relevance is while cross-sensitization test is very common, it does not always mean a severe clinical reaction will occur upon eating, although the risk is higher in humid conditions and also for elderly. So these are the scenarios. Now we have our advanced tests which are available, component visual diagnoses that can show us that this particular antigen is the cause for this cross allergy. So in that case, we can also explain to the mother that this is basically a cross allergy and not the actual allergy. But this kind of scenario may come that when the patient is not exposed to a particular field. A few days ago, I just find a patient in my area who was allergic to beef as per the report, and the mother belongs to a Hindu family and never taken any kind of beef. So he was very confused, and I just have to explain that this is basically cross reactivity and nothing but anything. So in my area, this is a very common notion to the mothers. The cold has come. Please do not give banana. Banana itself a very cold food. If we give banana, it will cause allergy. It will cause cold, something like that. So what is the fact behind that? The banana contains a diamine oxidase, which prevents degranulation of histamine present in banana and may act as a local irritant. It may cause symptoms suggestive of histamine intolerance, but they are uncommon. So some sort of itching, tingling in the mouth, that can happen sometimes. So with that, some sort of short duration cough that can cause after taking banana in some child, but that does not mean that the child is allergic to banana. True banana allergy is only 0.1 to 1.2% of all the allergic patients. So some patients with the birch allergy, they may develop oropollen food allergy syndrome after consuming banana. Now, here the child is not allergic because of banana, but because the child is exposed to birch pollen before. Which can cause a allergen to some foods. So birch tree pollen with these legumes, the seafoods, the stones, the tree nuts, they can cause some type of symptoms if they are allergic to birch pollen. The grass pollen, melons to oranges to potatoes, the sweet chard, the tomatoes, the ragweed pollen to antichokes to bananas, and the mugwort pollen to garlics, to mustards, to peppers. But this is a cross reactivity. And because of that, the child is developing some kind of symptoms. Is not actually allergic to this. This is a scenario that I just faced in many times. Thankfully, the last NCPC guideline has shown and clearly written that after 6 to 9 months of age, the child can take fish, the child can take egg. But in spite of that, this notion is very, very firm in the mindset of many parents that you have to delay all the animal proteins like egg, fish, the allergy containing foods like peanut in complementary feeding. It helps reducing food allergy. So the childs are unnecessarily deprived of this very nutritious food, and they develop malnutrition with the mindset in the parents that these are causing allergy. So there are very good evidence available against this. The first of all is the LEAP study, where the study focused on the infants at a high risk of developing peanut allergy, specifically those with a severe eczema, egg allergy, or both. So what it shows is that only 3% of the infants who regularly consumed peanut did they develop an allergy by age 5, compared to 17% in avoidance group. So those who avoidance peanut has developed more allergy than those who consume peanut. The long-term effect, a follow-up study which was LEAP on, and that shows that this tolerance persisted even after 12 months of avoiding peanuts, indicating that the protection is also long-lasting. The third was a LEAP trial that is ongoing research that suggests that the protective benefit of an early consumption continues into adolescence. So you start early, you get out of allergy quicker. Now, there's a STAR study that also suggested that early introduction of the egg to infants with eczema will introduce immune tolerance and reduction to the egg allergy incidence. So also we can introduce egg earlier. There are many other studies also, the EAT study, the STEP study, the BEAT study, the PETI study. They also show benefits of early introduction of the allergic foods. So this is a very bad myth that is causing nutritional deprivation of our children, and we should look into this matter. This is false. Now, this is a very common scenario. Cow's milk allergy, there is a very firm notion, the minds of the parents, that cow's milk causes a very high amount of allergy. There are many articles in the Google, there are many articles in the published papers or in the online journals that cow's milk allergy is going up and up and up. So the notions is very firmly in the mindset of people. So they used to look for alternatives. And the most common alternatives are the soy milk, and in some areas, in rural areas, they opt for a goat milk. So if you are allergic to cow's milk, you can take this. There will be no reactions. Is this true or not? The animal monoclonal antibodies specific for the cow's milk protein, they can cross-react with the major part of the milk proteins from the mammal blend. So you can have a cross-reactions. Weak cross-reactivity was observed with the milk proteins from mares and donkeys. But the problem is that none of these milk, the cow's milk, the goat milk, or the soy milk, they are nutritionally as good as that of the cow's milk. especially soy milk, has a many drawbacks when nutrition is concerned. And especially at the same time also, the Glyam BD30K or P34, which is a major soy allergen, that can cross-react with the bovine casein. And as we all know, the 10% of the child with the cow's milk protein allergy, they are allergic to soy as well. So you cannot avoid the reaction if you are going for that. So what does IAP says? IAP has a very clear guideline on that, published in 2022, where they say that if you're allergic to cow's milk and you have to take something, a milk like that, so just look at the kind of allergy. If the allergy is very severe, it just presents with a very severe kind of reaction, straightforward go to an amino acid formula. Now, if the amino acid formula you cannot afford, then in that case, or the allergy is not that serious, you can stick to an extensively hydrolyzed formula. Now, both of them are very costly, to the range of 1,600 to 3,400. So many parents, especially in my area where I'm practicing, they come to me for some cheaper alternatives. In that case, sometimes we have to explain to the parents that soy has many drawbacks. It has very less amount of calcium, very less amount of vitamin B12, but still then prescribe to them. Now, it's a scenario that I faced in many a times, and many senior pediatricians also, they have the same notion that when a child with wheezing came to you, the child with some arterial rash comes to you, immediately give a short course of steroid. A short course of steroid of 3 to 5 days does not harm. You can repeat it. Even in case of infection, you can repeat it under cover of an antibiotic. Is this true? Now, this is a very dangerous tradition. So there are very frequent bad reactions. There were vomiting, there were behavioral changes, there were sleep disturbances with respective incidence of 5.4, 4.7, and 4.3%. But the problem is that individual prescribed 4 or more courses of oral corticosteroids, they are a significantly higher risk of adverse events in first year. And these are osteoporosis, hypertension, obesity, or type 2 diabetes, GI bleed, ulcers, many things can happen. And the more you add on these short course steroids thereafter, the more the side effects build up. So we just have to avoid this as much as possible. Now, this is a very common scenario. In my hospital, there are many nebulizers, and with this season, many patients are coming with wheezing, and we used to start with a nebulizer which is present in our ER. So the mother has a sense that in spite of MDI, nebulizer is a much better choice. We should start with nebulizer because it gives me quick relief. So they think it's an effective and better. So they may go for that. And the cost of nebulizers has also gone down. So while parents are often prefer nebulizers, what is the evidence? And study shows that MDIs with spacers, they reduce side effects, they lower heart rates, and decrease emergency department visit. The amount of drug is only 50 microgram to 100 microgram, whereas in case of nebulizer, it's around 300, 500 microgram, which is very high. So as the amount of exposure to the drug is less, the heart rate is also less, and many a times the child is deteriorating and the mother is not using any kind of pulse oximeter, or they're using a finger pulse oximeter, which is basically not at all usable in case of a pediatric patient. Still, they're using it after the COVIDs, and they feel themselves as safe. And when it comes to the emergency department, the child is very, very sick, many a times needing PICO admission. So that nebulization use at home has always to be discouraged. The only advantage of a nebulizer is that it can deliver drugs without the child's cooperation. It can be given to a child who is drowsy, but home use of nebulizer has to be avoided at all cost. This is also a false notion. In my chamber, whenever I ask for skin prick test to our patients, it's only 10% or less than 10% of the cases the patients comply. They had many fears about the skin prick test. It is very painful. It is very, very risky. We don't go for that. They even tell me anaphylaxis. And actually, the risk of anaphylaxis is less than 0.02%. Now, we have very short lancets available, 1 millimeter lancets. For the elderly, we usually have a 3 millimeter lancet, which sometimes cause bleeding. Now, this 1 millimeter lancet has make our life very, very easier. It's very safe in a trained hand. If the child is fearful, we can go for reassurance, we can go for diversion, and we just stick to a small number of allergens, so we can just go out very smoothly, not plenty of allergens. So if there is any local reaction or a local itch, it can easily be controlled by oral antihistamine. A positive skin prick test has a good 50% reliability, but the more important part is that it has a very high negative predictive value of 95%. So we can rule out allergy to a particular substance easily with the skin prick test. Now, there are some situations where a skin prick test we usually not go for. like the child has taken an antihistamine very short ago, like the child has poor peak flow. So in that cases, or the child is having a eczema in their hand, we usually go for a blood test. But if a specific Ig level from blood and a skin prick test, both can be compared side by side, we can look for the blood free Ig and also the tissue Ig at the same time. So we are looking for two of the Igs at two different places. So it's a much better test than a blood test which only looks for the free Ig available in the blood, free specific Ig available in the blood. So this is also false. And that was the primary reason I have been very, very discouraged to go into allergy practice. My mentors and my seniors has told me that what you'll do going in allergy practice. You'll go for immunotherapy, but this is nothing but a co-curry. We have seen that many patients are going through that and no one has get any kind of benefit. So what is the science behind that? Allergen immunotherapy is a highly effective therapy at reducing symptoms and medication needs for allergic rhinitis, asthma, and stinging insect venom. Yes, allergy immunotherapy to the oral foods are coming up right now, but these are the three primary indicators where it gives a very beautiful result. This is the only long-term disease-modifying treatment, often providing lasting benefit for years after the treatment is stopped, and can prevent the development of a new allergies and asthma. The only problem, as we take time to develop the building up stage, it takes around 3 to 6 months. So in that cases, many a times the child, as the parents are not getting that kind of response which they expect when we start this immunotherapy, so they get disheartened. Success rate is 80 to 90% of the patients experience noticeable benefit. The duration is very important. At the start of treatment, it has to be tell them very, very clearly, it had to stick to this treatment for 3 to 5 years. A consistent long-term commitment. Sometimes we just tell them, yes, stick for 1 year to at least. Then when they saw benefit, they used to stick to this treatment. Now, the conditions treatment are very effective for the pollen allergy, for allergic rhinitis, or the allergic asthma, for the dust mites, which are causing allergic and asthmas. Now, the oral immunotherapies are also available, standardized immunotherapy also available for the dust mites and for venom. So this is also very false. So with that, I just come up to the end of my presentation. I very, very heartfully thanking our president, sir, our secretary, madam, Neeraj, sir, and all the dignitaries, Nita, sir, Sanjukta Di. Thank you for giving me this opportunity to present this auspicious platform. Thank you very much.
Excellent presentation, Dr. Bholanath. We can have question answers. Dr. Josh.
So, Dr. Aich, may I just clarify something that you have told regarding
Sure,
the
sure.
interactions of the cat and this dog dander? So, is it protective to keep the cat, or is it protective to keep the dog with the dander?
Sir, if you are allergic to cat and you are allergic to dog, to any of them, sir, do not keep any of them. And if you are very loving cat or dog, just keep a zone where the pest does not enter. But most of the guys, our recommendation is, if you're allergic to cat, avoid cat. If you're allergic to dog, avoid dog. But keeping a dog will not protect you from cat allergy.
So, it is not protective.
It is not protective, sir.
So, in your presentation, I would suggest, because I have heard it for the second time, so what would be the thing, not false and give a clear-cut message.
This is partially true, sir. This is partially true. Partially true for the sense, as I said, that dog allergy. If I'm allergic to cat, I can keep a dog if I'm not allergic to dog.
Yeah. So the clear message would be much more attractive in your future presentations also.
Thank you, sir.
Thank you. So it's a very mesmerizing talk. I listened to the second time, even the Howrah, but I skipped something. So I was waiting for your answer. Thank you so much.
Thank you, sir.
Excellent. All right.
Thank you, sir. Thank you, Dada.
Fine. Very good. Your majority are known to me. Still, the hearing is always a recap of the old ones. Thank you.
Thank you, sir. Thank you.
Sir, excellent presentation, Dr. Bhola. Dr. Reddy sir, if you give me permission, I would like to share a few slides just to on this very important point about dog and cat allergy with your permission, sir. Dr. Reddy sir? Or Dr. Soumya?
Yeah, please go ahead,
Yes,
Dr.
sir.
Please go ahead.
So I will just like to share this important slide. Can you see my slides?
Yes, sir.
Yes, sir. Yes, sir.
So this is one point which I just wanted to share about pet allergy. So about cat allergens, as Dr. Bhola said, so this is FeLD1, which is the most dominant allergenic protein about the cat, which is very important. And it is not the only one. Then there are other components also in cat allergens. So FeLD1 is definitely the most important, but these are from 1 to 8. So they are there. And FeLD1 is considered to be universally allergenic. So it is considered that suppose if some particular person is allergic or sensitized to FeLD1, then he will be sensitized to all the cats across the globe. So cats even include all the cat family and tigers also. So that means it is across the globe, it is universal allergen, and it is considered to be the most dominant allergen. Then the other thing about coming to the dog now. So in the dog, there are certain allergens which are like CAN F1 to CAN F7. Out of these, now these CANF1 and is considered to be, you can say, like most important, but then sometimes CANF2, CANF4 and CANF6 can also be there. Now what I wanted to say is that there is a cross reactivity between cat and dog. So if you just see that CANF6 and FeLD4, so they are having cross reactivity. What I want to say that if somebody who is having CANF6 allergenicity, then at that time uh, he might react to cat also with FeLD4, and vice versa it can happen. So if suppose somebody who is having a you can say like a reaction to FeLD1, which is cat allergen, then at that time it is not having any cross reactivity to the dog allergens, but it will also not provide any protection to the dog allergy, which we need to understand. So but if it is FeLD4, then definitely it is likely to have, you can say, like a cross reactivity to the dog allergen also. So this is one concept which is about the cross reactivity which I wanted to share. The other thing is about the timing of exposure of cat and the dog. So it is said that if the person initial 1000 days of life, that means from conception, that means when the mother is pregnant up till, you can say, like the 2 years of age, so the microbiota of the body is rapidly changing, and at that particular time the more diverse the microbiota, it creates more beneficial effect. So it is said that if somebody who is having dog at the time of you can say like pregnancy or during first 1 year of life, or especially in infancy, then at that time it is possible that this particular dog, when he is going out, he's getting a lot of microbiota from outside inside the home, and the child either in utero or, you can say, like in the first year of life, is getting exposed to that microbiota, and probably getting, you can say, like lesser allergenic. But the same dog or same cat, if he's getting exposed to somewhere like second or third year of life onward, then at that particular time, now the microbiota or the allergenicity potential is already developed in the child. Then at that particular time, it becomes difficult and they will be more allergenic. But these all are the, you can say, like concepts in different papers. There is no concrete, I will say, evidence or no concrete guideline which will say that, okay, you will keep the dog at this particular time and don't keep the dog at this particular time. So there are no concrete answers to that.
Thank you. Thank you, sir.
Yes, some questions in the chat box are like, what is the base test for drug allergy by Dr. Sanjukta, sir? There are many tests, sir, I think, for drug allergy. Yes.
There have been no questions from the YouTube. Bonanza sir, if you can answer the ones which are come in the chat box, that's all the questions.
Yes, sir. Yes, sir. So there are two questions. What is the base test for drug allergy? Sir, it depends on the dog, sir, which is being. So the penicillin has a separate kind of test, and yes, there are some skin prick tests which are available for drug allergy. Some other tests also is there, sir. Like we can go for intradermal test for drug allergy. Many a cases, sir, if I just think that this drug has done something very bad, so the best test is to avoid that drug altogether. So there is not a very single test which I can say that is the best test for all the drugs. It depends on the particular drug to whom I am searching that I'm allergic to it or not. So there is no best test for allergy. It's for that particular drug, particular test. And if the drug is serious, should not take the drug at all. And then second was Mitesh by any blood test available for penicillin or NSAID allergy? Yes, I think there was some test available for that, sir. They usually skin prick test, sir, usually done for that. In some centers.
Can you please highlight about that parakeets and the birds, the lovebirds that we keep in our house? Some are
Sure.
fond of the lovebirds and the parakeets. So, or even the pigeons. So,
Yes, sir.
what is your take?
Sir, allergy to the pigeon feather or the bird feather can happen, sir. In that case, what we can do is that, sir, for pigeon, we can the feather is allergic, sir. The feces is allergic, sir. So we can go and test ourselves for that, and simply if we can develop some kind of symptoms, sir, we can also look into that. But most importantly, sir, there are some tests for pigeon available, sir. I just can't remember that, sir. But that test we can go for that and find out that whether I am allergic to pigeon feces or the pigeon feather. So that can help us.
Actually, interstitial lung disease that occurs.
Yes, sir. Yes, sir. It can have a
Interstitial
hypersensitive
lung disease is a
pneumonitis.
very dangerous one.
Hypersensitive
I
pneumonitis is
have
very
got
dangerous.
one patient of the interstitial lung disease. So how we should take care, because previously we don't know whether it will develop or not. Most of the house in Bengal, they have got this pigeon.
Yes, sir. But this is a hypersensitivity pneumonitis, sir, which is a type 3 hypersensitivity. So the best part is, sir, we should avoid entering them in our house. So there are many measures, but avoiding entering pigeon in our house is the best way out, sir. Because once we develop the interstitial lung disease, sir, it is very, very difficult to
Yes.
get out of that.
So, thank you, Dr. Bulanath. It was an excellent session.
Thank
You have cleared the many myths regarding food allergy, drug allergy, milk allergy, and there are so many myths prevalent among doctors also and parents, right? So once again, I thank you, Chairperson Sir, Dr. Neeraj Gupta Sir, Soumya Madam, and colleagues and dear friends. So on behalf of Allergy Chapter, we can conclude the session, and we all see you in the next session in March. Thank you. Thank you, sir. Thank you, madam.
Thank you. Excellent
Thank
session.
you.
Thank you.
Good night.
Thank you. Thank you.
Thank you.
Good night.
Good night.
Good night.